thank you so much. I'm delighted to be here, and thanks to Professors Mulligan and Phillipson for the invite. So I'm going to present research on scope of practice, licensing for nurse practitioners, and healthcare costs. All right, so this is joint work with Alexandra Wallace of Georgia Tech and Danny Hughes of Arizona State. All right, so this is a map of healthcare provider shortages in the United States. So if you look at the map, darker is bad. So if you look at most of the country, it's covered by a portion of the county is covered by a healthcare provider shortage area. So suburban Cook County is doing okay, like Northern Virginia is doing okay, but by the government's own classifications, much of the country is a healthcare provider shortage area. In many ways, I think of this as an example of government failure. We make these nice maps, and then we're done with it. All right, so I actually think this map is not very useful just because it shows most of the country is a healthcare provider shortage area.
Just for clarification, define how the government defines shortage.
It's based on a number of primary care providers. So they only focus on physicians, yeah, per capita. So I think Joe Grogan and others at Paragon are doing updating the statistics using nurse practitioners.
Like the threshold below providers per capita below a certain threshold.
Yeah, a certain number, which I don't know off the top of my head. And also the county has to apply for it. So the county has to apply for it and the government designates it. Based on this map, nearly all of the counties have applied for those. So
that's for financial reasons.
yeah, exactly. And so nearly everybody applies for it. All right, so my point here is much of the country is a healthcare provider shortage area. I like this map, which looks at primary care physicians per capita, per 10,000 people. And you can see that much of the South, or a lot of the South, has very few primary care physicians. So a point of this is that when we talk about policy, we often focus on demand-side interventions. But in order for demand-side interventions to be effective, you do need to have some providers. So if you look at the geographic variation outside of like the affluent areas or areas that have like medical centers, you generally, a huge chunk of the country has a very low density of primary care physicians. This should say physicians. All right, so I'm going to talk about nurse practitioners. So when we talk about shortages in the US, this conversation is not new. We've been talking about nurse practitioners since the 1960s. They originate in 1960s concurrently with the emergence of Medicare and Medicaid. So they're an advanced practice registered nurse. So they're registered nurses with additional clinical hours and more credentials. Usually they have a master's degree or a doctor's of nursing practice. So Kaiser Permanente says that, they could perform 80 to 90% of the tasks that a primary care physician can. That's their number, but just keep in mind that there's some degree of substitutability. And they can also obtain certification and specialization in certain types. So nurse practitioners can do pediatrics and so forth. Most of their certifications are in primary care or adjacent fields. So key thing in mind is that, we don't need government regulation to identify qualities. We could have like a voluntary certification system. So why are nurse practitioners interesting? They've been growing really, really fast. So we have almost as many nurse practitioners in the country as we do almost as primary care physicians. All right, so what scope of practice? Scope of practice, I missed this slide. Yeah. So scope of practice are regulations determined at the state level that delineate tasks and services that these nurse practitioners can perform. In certain states, they can prescribe you antibiotics. In certain states, they can't even do that. And so what's interesting here is there's considerable geographic variation in the US on what tasks an NP can perform. So historically, the literature breaks this down to independent prescriptive authority. Can a nurse practitioner give you a refill for your statin? Can a nurse practitioner give you a refill for your metformin? So in certain states, they technically are not allowed to independently do that. In other states, they can independently prescribe and then can also treat you. So in states with what we now call full practice authority, Your NP can serve essentially as a primary care provider. They can see you, they can provide care, they can write referrals to you. So one thing to keep in mind is that they might be substitutes for certain types of physicians, primary care, but they're also complements. So if you go in, the NP could be like, yeah, that looks like cancer, or I'm just gonna refer you to a skin care specialist. So the AMA generally has opposed scope of practice laws, but you have to keep in mind they're complements and substitutes to physicians. All right, so this is the map for full practice authority in the United States. Illinois implemented FPA in 2021. California, I think, also implemented it. So based on where we are in the country, eventually all the states will have to adopt full practice authority. But this is the map. We still have plenty of states that have not implemented full practice authority. All right, so what is my research question? We're going to look at how state level scope of practice laws that grant nurse practitioners full practice authority, how do they affect cost and utilization for diabetes related healthcare? So the previous presentation is very useful. Clearly, we're going to go there as well, but we will still need, the way our medical system works is that we'll still need somebody to prescribe your Ozempic to you and then to monitor your Ozempic. All right, so the nice thing about our study is that we have granular commercial data. So we're actually looking at people like, well, most of us who are on commercial insurance and the people on Medicare Advantage. So that's private Medicare. So it's publicly funded, but it's administered by private companies. All right, so our idea is that maybe if we look at claims data, we can unpack some mechanisms. And what we're saying is that any result that is well-powered has policy implications. If we can show that, implementing FPA has no effect or no harmful effects on the population, that makes a case that states ought to get rid of these laws. And if there's some harmful effects, then that provides a justification for why these laws should be in place. So historical evidence suggests that there are some benefits to occupational licensing. So Kofi Charles had a JPE that showed initial midwife licensing laws early in the US history, like sometimes in the 1920s. They actually did serve as a way of producing quality healthcare providers. Jason Fletcher also has one on a historical study. So historical studies show that a couple of historical studies show that when we went from no licensing to some licensing, there were quality gains, or the licensing was able to separate out or separate out quality providers. But there's also the opposite side. You can go too much on licensing. So it could be a Stiglerian story of capture, that you have too much licensing and you're restricting supply. And so our point here is the licensing a priori can have ambiguous effects. It could potentially be positive, it could be potentially negative. But depending on our results, that can kind of indicate where we are on this optimal licensing question for society. All right, so why is this important? There's a University of Chicago health policy study that came out in the Journal of Internal Medicine that talks about a primary care physician would have to spend 27 hours in a day to monitor everyone's chronic conditions. Physician burnout has been going up over time. Physicians are more likely to specialize and rather go into primary care. So there's lots of shifts going on. There's a predicted shortage of physicians by the American Association of Medical Colleges. And why are NPs important? NPs are not constrained as physicians are. So the CMS has a residency cap. Physicians generally grow at 1% a year. Nurse practitioners can grow faster. They can grow at they've been growing at 9% a year. There's still some supply constraints there, like nursing preceptors. But the key difference between the nursing profession and the physician profession is nursing has more free entry than physicians. And so the number of nurse practitioners has doubled between 2007 and 2020. And about 20 states still have these laws. So it's still very policy relevant from a state policy point of view. All right, and I'm talking about diabetes. So diabetes has a very high prevalence. The official prevalence in 2018 was 14%. And a considerable population is at risk for diabetes. They have pre-diabetes because, they're obese. And so diabetes requires continuous maintenance. And diabetics are very expensive. So diabetics experience or diabetics incur about 25% of all medical expenditures in the US. And half of those are due to the diabetes itself. So I'll just say I got this slide after watching Professor Phillipson do an interview on CBS. I think you were talking about Ozempic and diabetes. So, but when we're talking about costs, you have to keep in mind, healthcare is not just about utilization and cost. A big value of healthcare is the private benefits. So it's not just that, as our study is going to look at healthcare costs, there's a huge private benefit to improving health. Good health has a value. So Becker has a VSL paper, Murphy and Topel, The Value of Life and Longevity, and Phillipson, Becker, Goldman, and Murphy on how end of life, extending life at the end of life has a considerable value. So when we're talking about healthcare costs, we're looking at insurance data. But one thing to keep in mind is there's a huge private benefit to improving health. All right, so what do we know about nurse practitioners versus physicians? So Mundinger has a JAMA where nurse practitioners were compared to primary care physicians, and they find that NPs are generally provide a similar quality of care in the primary care setting. So there's another RCT, and Yang has a comprehensive lit review. Some of these are causal, some of these are non-causal. What do we know about the labor market? So what do these laws do in the labor market? So they serve as constraints. So they probably distort the labor mix at hospitals. They probably distort what kind of services NPs can provide because, they're regulated from providing these services. So generally, studies find that getting rid of these laws improves the labor supply response. So NPs are more likely to work. Part of this is how NPs are employed. Generally, NPs are salary. Physicians get paid on RVUs. So when you have full practice authority, NPs are actually, some of them can actually shift into this entrepreneurship where they're also compensated based on services provided and move towards an RVU model, where then there's an incentive for them to potentially work more. All right, so the effects on labor supply are modest, but this is one of the pathways. So one thing to keep in mind about labor supply studies is they're looking at short-run outcomes. It takes about 4 years to become an NP. So all these studies are mechanisms, but they're likely to underestimate because they don't account for the entry effects, right? So if nurse practitioners can function independently, they might open up clinics and so forth, and that's going to be captured with the lag. What do we know about health effects? Diane Alexander and Molly Schnell have a paper that shows that full practice authority is associated with improvements in mental health status, reductions in suicides. Kim Groover shows they're less likely to prescribe opioids. Professor Mitchell has a study that shows that, outcomes for diabetic debridements improve in states that implement full practice authority. So nearly all of these are diff and diff papers. So the key papers that I want to focus on is Ben McMichael's. This came out in the Journal of Public that shows that states that expand full practice authority have a reduction in amenable deaths. So I like to think of this as saying, like, look, these policies are killing people. These arbitrary, idiosyncratic policies are killing people. So states that have full practice authority have a reduction in amenable deaths. And so if we believe, and we're at the University of Chicago, so if you believe in that, the value of health and life extensions matter, then this is a considerable inefficiency that's introduced into the system because of regulation. And Sarah Markowitz does a comprehensive study of medical malpractice reports and adverse action reports. So again, this is another diff and diff study that finds that full practice authority is not associated with increase in medical malpractice payouts or adverse action reports. So a big claim by people who support scope of practice laws is that they argue that maybe, NPs are not equal quality as physicians and they're not as safe. And so I think medical malpractice is one big way of looking at whether they're safe or not. And we see no changes in malpractice. All right, so pretty much most of the literature generally finds full practice authority for nurse practitioners has positive outcomes on the health side. There's one study from the VA. So this is not a diff and diff, but they're just looking at provider heterogeneity. And they're using a probability of getting assigned to an NP. So if you go to the VA at 8:30 and you're at a hospital that has more NPs versus you go to a VA at 8:30 in a hospital that has fewer NPs, they're looking at this intensity measure and instrumental variable strategy. And they find that if you're seen by an NP in the VA emergency room, you're likely to have longer stay and some higher utilization. So this is probably the closest study that finds some negative outcomes. But we have to keep this in mind. This is the emergency room. And they have a sample of 156 nurse practitioners. But in the interest of being comprehensive, there is some effect. So there's some evidence that NPs could potentially be harmful. And so this is an NBR working paper. But overall, the literature suggests that NPs generally have improved population health. And McMichael's, I think, is the most important, that shows that, changing certain laws, we could save lives. All right, so what's the mechanism? Licensing tends to reduce entry. Aaron Yelowitz has an SCJ that shows that even modest barriers can reduce entry. So part of one of the ways is that, these laws probably help more NPs come in. They're also likely to increase provider density. NPs are more likely to serve in rural areas. And NP wages are different than physician wages. They could probably support a clinic in rural Arkansas, which consists of mostly Medicaid and Medicare patients, whereas somebody who's a primary care physician, they likely don't want to go to Hope, Arkansas. The other thing is I'm going to steal Professor Mulligan's phrase and talk about business model innovations. So NPs have resulted in the rise of rural health clinics, urgent healthcare centers, and this reduces the time and money costs of getting healthcare. So they do bring in some efficiency into the system. When these laws are reduced, there's no administrative burden. So technically, a physician has to do a chart review. Physicians have to do collaborative practice agreements. So these laws, again, impose constraints. And these laws also probably restrict how a healthcare provider like a hospital can allocate talent. So if you have these scope of practice constraints, a hospital might not be able to assign an NP to a general simple case. If you go to the ER just because you're homeless or something, it's an inefficient use of resources if you're seen by an ER physician versus potentially an NP. That's a terrible example since I talked about how NPs can do, or there's some paper that shows that NPs perform poorly in the ER. But there's a lot of mechanisms. Many of them have not been tested outside of the labor market. All right, so what data are we using? We're going to use Optum's Clinformatics Data Mart database. So this is a large commercial claims database. It has about 48 million people across 50 states in the US on commercial and Medicare Advantage plans. So we use ICD-9 and ICD-10 codes to separate out people who had claims for diabetes mellitus. So we observe every claim. The nice thing about Optum is that we see all the claims that are submitted, claims that were approved, and claims that were denied. For a subset of 30%, we also have lab data. So we have their A1C score. The CDM manager told us it's as good as everybody else, but as economists, we're always a little suspicious. Why do you have 30%? But we'll take them for their word. So we aggregate these claims to the county by quarter level, following Ben McMichael's and Hughes. So the reason we do this is not everybody with diabetes has a claim every quarter. And especially if your diabetes is well maintained, you might actually have fewer claims. And again, the key thing to keep in mind is this is commercial insurance. So people technically can leave. If they go to another employer that does not offer coverage from a CDM sponsored plan, then you drop out of the sample. So to kind of maintain consistency, we aggregate up to county by quarter, and then we calculate the number of enrollees. We also merge in data from the area health resource file. So these are some other control variables. And our data set on full practice authorities from Ben McMichael and Sarah Markowitz. And so they have the comprehensive data set. They've gone through the state statutes and they've done a binary classification 0 or 1. So Ben is a lawyer. So his data set generally corresponds pretty well to other data sets. And they've been more thorough. All right, so we're just going to do the bread and butter for applied micro. We're going to do a two-way fixed effects difference in difference model. So our outcomes are standardized costs. So one thing to keep in mind, so these are the costs that the insurer pays the provider. And then we also have out-of-pocket costs. So this is the copay, coinsurance, and deductible. We have some health outcomes, debridements, A1C score, number of A1C tests, primary, and the total number of primary care claims, the total number of non-primary care claims. Our key parameter of interest is the coefficient on full practice authority. We also have some event studies to kind of validate the diff and diff. And then we do the newer diff and diff estimates because of the concerns on staggered implementation and differential timing negative weights. So that literature is very fast evolving. All right, so these are our descriptive statistics. So in our data set, the average diabetic had about $2,300 of claims per quarter. So that's about $9,200 per year. So that's our cost variable. The out-of-pocket costs were about $164 per quarter for the average. All right, so these are our main results. We generally see a reduction in costs in urban areas, but we see no differences for out-of-pocket costs, no changes for diabetes claims, no changes in primary care. There seems to be some evidence of reductions in non-primary care claims, and no effects on the lab data. And so our first study was county level analysis where we don't add weights. In our second estimation, what we do is since this is county level, we weight the counties by the number of enrollees in each county. So this is our weighted regression. And we generally see the cost for diabetic care goes down by about $480, so about 15%. We see a reduction in non-primary care, no change in primary care, and generally no change on any of the biometric data.
Answer what you expect, shift away from spending. These nurses are allowed to do more things.
And they're reimbursed at a lower rate.
The fact that they shift spending away from non-primary to primary. With the net savings.
Yeah, so we don't generally see, so again, this is not statistically significant, but the evidence is suggesting that we're switching away. But we're not making the strong claim. But yes, there is some evidence that we're shifting away from non-primary care to primary care.
MPs are going to show up in the primary care setting. So we do it.
Yeah. So that's part of the motivation is that, I mean, that was part of the motivation for the ACA as well. You're going to get more primary care, so you won't use emergency care. In the ACA case, we found out that they're actually complements. You use more of both. You go to the doctor more, and then you go to the ER both. All right, but we see, so our biggest effect is that, the payments are going down. So the payments from the insurer, or the payments that the insurer is making to providers. So that could probably reflect that they're shifting away from more expensive non-primary care services too, or just better maintenance.
Sorry. Hi. A question. Sorry. In your claims data, do you have any demographics on the individuals who claim?
So we have gender. So this is at the zip code level. So gender. I think they run an imputation on race based on names. So it might not be high quality, but there's a race and gender variable. But again, claims is very limited. We know where they work. We know their group plan, but if they're employed, but not a lot of demographics.
Okay. And sorry, how many policy reforms were there in the sample period you considered?
So about 6 or 7 states actually changed their full practice law.
Okay.
Yeah.
No, because I was wondering why you needed the aggregation to the geographic level at all. I mean, you could literally use the panel and even potentially control for unit fixed effect, like individual fixed effects, to absorb a lot of variation that probably is driven by individual traits. That could help with power. That's why.
Yeah, yes, so that's on the table as that, just to redo it. It really depends on job tenure. So Allison pointed out that, it might be like 4 years. That might be enough to observe people. Even for Medicare Advantage, we probably can observe them until they get too sick and then they go into traditional Medicare. But you're absolutely right. We could have just done it that way. And so just to be consistent with the,
So, how does medical liability work? Is that working equally on nurses and doctors, or is it because nurses don't take out insurance premiums for medical liability, do they? Or no?
so nurse practitioners, if you're in a delegated practice state, the physician that you made a collaborative practice agreement, you're on their malpractice insurance. So if you decide once full practice is implemented that you want to set up your own practice, then you would have to get your own
This is very, very analogous to drugs where we have licensing through FDA, and then we have product liability after you're on the market. So it's a pre-market screen through the licensing called FDA in that case. And then there's a post-market penalty through the product liability. Here it's very similar, right? The licensing is, you try to prevent bad service through licensing, although it also protects the incumbents or whatever, right? But also you have the liability on top of that. Now, if the liability is working, it seems to me this should be very little effect of, because the doctors and nurses, they might know good nurses, this nurse can handle this nurse is screwing up everything, we don't want to go near the patient on this topic. So they will handle that according to the medical liability that they know they're facing in some sense, right? So the question is, wouldn't we expect that under medical liability that covers both, that there should be very little effect? Because that's ultimately the incentive for them to get it right. Obviously, they care about patients, but that's the additional incentive to get it right.
Yeah. And yeah, so I think the malpractice study finds what you just mentioned, that they don't see that. So you're right, there is kind of this heterogeneous kind of response, right? So if you're the MD, you know how to allocate your staff.
Good ones for bad ones.
Yeah.
So-
You're the bad ones are like, just take the blood pressure,
So, but I'm wondering, like, there's obvious cost raising effects of having licenses, right? They're protecting incumbents and you make it more cumbersome for people to do whatever. But, so that's the cost side. That's like product liability in that. It's the opposite of drugs. But product liability raises drug prices a lot, but you have to worry about, getting sued for the side effect. Here it's the licensing that raises costs.
But also there's like a Roy models type of self-selection. So if you're a regular nurse and you're like, I'm bad at my job, you might not want to invest in getting the additional credentials to become a nurse practitioner. So there's still another mechanism where you do have to take additional clinical hours. And so that probably also serves as a barrier or a screening.
All I'm saying is that there's two ways that safety is regulated. There's the pre-entry, which is licensing, and then there's post-entry, which is liability, both for drugs and services. So the question is, would you expect a pre-entry effect, which is you're saying, if we license more people, do we need to license people to do this, and do we not need to license people to do,
But we don't know that the licensing is for quality. You're just assuming.
Well, no. Yes, I assume it has
If you
some
listen-
that screening ability on,
You could assume, take this as a test of what's the licensing doing? It's distorting the allocation of tasks.
No, that's fine.
In a
I'm
way-
fine with it.
in
It
a way
raises
that creates
costs. That's
runs.
all I'm saying. It
Yeah.
raises costs.
Yeah,
That's fine.
that's what he has.
Yeah, it raises costs, but then the trade-off is the argument you said, which I think most politicians care about, and the doctors dress up as caring about. They don't care. They just want to protect. They just want to have a little competition as possible. But the politicians will say this is going to be unsafe. We don't want nurses to do surgery. We all agree on that.
Yeah.
So the question is, where do you draw the line? And then that's a safety issue, but if they're covered by the product, but by the medical liability, that should not be.
No insurance company reimburses nurses for surgery,
Understand?
right? Like there's lots of barriers on that. If you're an NP and you said, I'm going to do cabbage, I'm going to do heart surgery, you are not going to get reimbursed by the insurance company for that. No reinsurance,
No
no.
one's claiming they will. I just.
But
said that's-
but sometimes physicians say, oh, well, they're going to do surgery. Like, well, how are they getting paid by that? But that is a common thing for physicians to say on scope creep. Oh, NPs are going to do brain surgery. They're going to do heart surgery. No, they're not. They're not going to get reimbursed for that.
Yeah, that's a third screen you have
Payment.
insurers.
Yeah,
You have the liability if you mess up, the insurers don't want you to mess up.
yeah. I mean, there are some very small surgeries, and there's actually 3 states that let NPs do vasectomies. As far as I can tell, no NP has ever done a vasectomy.
But yeah, I was gonna ask if you have, in these examples where states opened up, did you have any insurers in those states say, we are not reimbursing if you have the MPs involved in X?
I'll have to look into that. That's a good point. But you're right. That actually is another screen, right? The insurer actually ultimately decides who gets reimbursed per procedure. So I think Steve Parente has a very interesting paper on CRNAs that are nurses that are specialized to do anesthesia. So in states where they're not reimbursed, surprisingly, they don't do that. But in states that are, then they will supervise it. So that's a good point, and I will think more about that. Actually look into whether insurance, how insurance has responded, and if they've generally
In some
covered.
sense, in-house, they did a study like you did. And then, but they're using it for commercial purposes.
Yeah, yeah, I'm sure. Yeah. So just to kind of go with the flavor of the month in econometrics, we've done the additional estimators, and again, our costs showing up. So these are the unweighted regressions. So generally, we observe reductions in costs, the standardized costs, and we see some evidence of reduction in non-primary care. We also do event studies. Again, the way as you mentioned, the way we've done it is just that, it's 3,000 observations since we've aggregated it up. So you see these big standard errors. So we separate them out by urban and rural. So all 3 estimators. Again, this has fallen out of fashion in the last 6 months that I've done it. I think the rule is now you should show them separately. All right, so these are out-of-pocket costs. They're just wide standard errors, but you don't see any parallel trends. All right. So keep in mind that this study is only looking at commercial data, right? So this does not, to go to Professor Phillipson's point, a lot of times legislators care a lot about what is it going to do to Medicaid costs. Because I think once you get sick after you're 65, they're like, you're the federal government's problem. So this excludes the Medicaid population. And if you're cash paying, then you're clearly not in, right? So if you're cash paying for all your services for some reason, you're not in. All right, so keep in mind, this is a short run study. So long run outcomes might be better if if there is actually substitution. And if there's entry. So this is relatively cheaper than typical government plans, because government plans usually cost a lot of money. So when we talk about policy interventions to improve access to care, again, so I say improve access to care in terms of increasing the number of providers. So interestingly, I think this policy is interesting because it causes distortions in inputs and outputs. It causes distortions in the labor market, and it can potentially cause outputs. It could cause distortions in the health markets because we have fewer providers, fewer services. And I'll end with Professor Mulligan's point. Just because you have an insurance card doesn't mean that you get seen, especially if you live like in a rural poor county. So conclusion, we need to also think about supply side. So that NPR study was focused on increasing reimbursements. Look, physicians already work like 55 hours. Increasing reimbursements is likely just a transfer to them versus actually getting them to do more. So there's tons of studies. The FTC wrote one. There's policy pieces in the New England Journal of Medicine. So this is generally a low-cost intervention. And This is likely a $20 bill that we have in the state policy sphere but we can't pick it up because regulation costs are like $30. So I'll end with that. And thank you so much.
Thank you. I don't know if this mic is on, but I hope everyone can hear me. My name is Katina Latham. I actually teach a course here, but I'm also a director of the healthcare team at GAO. So I think this is a very timely work. I just wanted to provide some context for you to think about as you move forward. Just on the, as you mentioned, increasing the provider supply and, elevating the role of an NP would certainly help. But I think you should also just make sure you note the challenges, as you point out, with the nursing shortage in general, post-COVID, and just the availability of nurses. And in fact, nurses now don't even want this role. And that most of them are moving, a lot of the NPs in particular, are wanting to move more towards administrative work. So just something to bring into that context that further challenges the availability of the nursing supply, which I think would be helpful.
Yeah, I think that's a good point because Mitch testified in Pennsylvania, and that was the argument that the AMA had put out. It's like, well, if you let nurses become nurse practitioners, we already have a nursing shortage, so we shouldn't do it.
Right.
But so that's a good point. And I think that just tells us that, we have bottlenecks, we have constraints because there aren't enough preceptors. But yes, noted.
I'd be curious to hear you elaborate. You said there's an interest to shift toward administration. So what's the thinking? Is it compensation or lifestyle or what is it?
Lifestyle, I think just like everyone else, they want to be able to work remotely. They want more flexibility. They don't want to sort of be tied to providing the bedside patient care.
All right, thank you.